Dr. Murphy? You're Dr. Murphy.
Yes.
Sit down, please.
Thank you.
Did you have a hard time getting here today?
It was rainy this morning.
Yeah.
Yeah, traffic was crazy.
Yeah, the traffic's awful. Well, let me go over just a little bit. I'm sorry.
I have the case here.
Okay. Let me go over a little bit my understanding of my role, make that a little bit clearer, and then I'd like to ask you some questions to make sure I understand the medical side of this, and then a couple of questions about your relationship with the family and your experience with them. And then we'll bring them in pretty soon. My role is, as the ethics consultant, is to basically clarify things, try and see where the ethical conflict is, and do what I can to facilitate, or even if necessary, mediate a resolution. But the focus is on trying to see where the ethical conflict is and make recommendations. Not that I decide anything, I don't decide anything, I just make recommendations and I try and help communication. Is that all pretty clear?
Yes, it is.
Okay. Have you participated in ethics consults before?
I will say no more than two. More than
Okay.
2 times before.
Do you mind if I keep notes?
No, I don't.
It's a lot of detail. It gets fuzzy in my head sometimes. You are the attending for Ms. Henderson, correct?
Yeah, correct.
And what are her medical problems?
Well, he presented with a stroke.
She.
Right?
She.
Sorry, she presented with a stroke. It was very serious, of course.
Okay.
Patient had to be intubated because of airway protection. And then, of course, she had more complications after the stroke.
How long has she been intubated?
How long?
About how long?
That was like I'm not sure. It was like less than a week.
Okay. And how long has she been admitted? When I understand she was transferred from a hospital. Do you remember approximately how long?
Yeah. So she was transferred from an outside hospital. The day after the stroke. That's what I have here in my notes.
She's been admitted about a week, roughly?
Yes.
She was intubated pretty quickly. Right, okay.
So a surgery was one of the options. Try to decompress the pressure that the swelling of the brain was causing against the skull. So opening the skull was one of the options. But the nurse surgeons determined it was not going to be helpful. So there was a point of discussion as well. To how beneficial will be that intervention in this type of patient.
Any other medical problems that I should be aware of?
No, that I know of.
Okay. And
I don't have the complete medical history here, but so no that I know of.
so the diagnosis is a stroke with no other complications at the moment. Is that right?
Ischemic stroke.
Ischemic stroke.
Yeah.
How about prognosis? What's your prognosis for this patient?
Well, the area of the stroke was 7 centimeters in major territory. So the airway had to be protected. The reason why the patient was intubated. I think that prognosis is not good.
Okay. So, have you been able to assign a probability in terms of percentage of not surviving?
These type of cases are really challenging in order to determine a probability. That's something that we were never able to predict everybody's different. Every brain is different. So people have more chance of recovering. Some other patients have less reserve. So you could see the same type of stroke, the same localization, the same extension, and some patients do better after months of rehabilitation, and some others just can't make it. So I can't give you a number. I can give you a percentage of.
Okay. I asked only because I'm sure the family, or I'm pretty sure the family's going to want to know that, so I thought I would ask ahead of time. Are there more tests that you plan to run in the next 3 days?
Well, given the fact that the patient is intubated, I will just obtain daily winning parameters to see if the patient is responsive and if she's able to come off the ventilator. That will give us like a general idea if she's able to breathe on her own, and if she doesn't need the ventilator anymore, and if her mental status improves. Probably an MRI will be useful as well.
Okay.
To make sure there's no extension and there's no forward bleeding within the area of the stroke, because that sometimes happens, and it's one of the complications of the stroke. There's bleeding in the surrounds or within the area of the stroke. So the MRI sometimes happens. The MRI sometimes helps.
Okay.
More tests, I wouldn't. Well, the patient was transferred over our institution, so it will be just a matter of completing the stroke workup.
Okay. Is it fair to say that you're really in the middle of assessing her condition and her prognosis?
Yeah. Yes, because I don't have for example, I don't have the exact cause of the stroke. What did it cause it? There will be several mechanisms. Because I would need, for example, the MRI study.
Okay.
That will be an echocardiogram to make sure it's not a cardioembolic stroke causing this type of obstruction in a given vessel, and then an ischemic area in the surround of that vessel. And some other blood tests that will probably help us as well.
How many days do you estimate? And I understand, again, medicine is an art and an inexact science at times, but do you have a rough idea of how many days before you can firm up a prognosis for her?
Roughly, I would say 3 to 4 days. Obtaining all the tests as soon as possible, of course.
Okay. And my understanding from having looked at the chart, she is responsive to some stimulation, some levels of pain. In your opinion, is she suffering at all? I know she's sedated for the intubation. Do you think she's in pain or suffering?
Well, part of the winning trial is shutting down the sedation. So the patient will be off any pain medicine or any sedative medication. And at that point, we will be able to assess if she's in pain. The breathing tube, the endotracheal tube, of course, will produce some discomfort. And at that point, we will be able to see if she gets agitated or if she's really in pain somewhere.
Okay.
Yeah.
And again, I'm asking these questions because I imagine the family will at least have them in their mind.
Sure.
So, and I think among the family there's been a discussion about withdrawing life support. There's a difference of opinion about whether that should happen. Have you had discussions with the family about this? What was your understanding of what the family believes should happen?
I actually had a recent case, like let's say 2 weeks and a half ago, where it was in the middle of the night, and it was a massive stroke, actually hemorrhagic, affecting the speech area and the motor areas. And I had like 15 family members getting all together and requesting to talk to me. They understood the prognosis was not good, not only because of the stroke, but also because of the complications. The patient had pneumonia, became infected and septic, and chances of recovery were minimal. She was not going to be the same as she was before. She was not going to recover speech. She was not going to move the right side. And I think she expressed to some of the family members that she wouldn't want a lot of things to be done. So that's why they got together that night, and we came across with that decision altogether.
So how does this case compare to that case?
Well, stroke cases in these type of decisions are similar, because sometimes we have to put in valid, we have to compare what are the chances of recovering depending on where the stroke is, and also we have to put on the table what the patient probably wants, or what the patient would express at some point in her life or in his life. So in this case also, the similarity is that we probably have a suggestion that she didn't want a lot of stuff to get done.
My understanding from reading some of the chart notes is you're not comfortable with the withdrawal at this time. Is that correct?
That I was not comfortable?
Yeah.
Well, I always play with some hope. I wouldn't, I think as a physician, I wouldn't like to give up in a matter of 2 or 3 days. I would like to fight a little bit more. So sometimes I just tell the family to wait, and if I don't see anything, at that point I will say, well, it's time to withdraw.
Okay. So let me summarize a minute. She has an ischemic stroke. She's intubated. You still have some assessing to do. Is she dying right now? Has that process started? Okay, no? Okay.
No, she's not actively dying. She's stable. Everything is stable at this point.
And what is your opinion about the medically appropriate thing to do right now for her? It's to, my understanding from what you just said, it's to wait a few days, continue to assess, and then reevaluate. Is that correct?
I think yes. I think my best, my best decision at this point would be evaluate if she's able to come off the ventilator, if she's able to breathe on her own, and if she's not able to, at that point I will say it's time.
Okay.
It's time, because she would be then ventilator dependent, and that will prolongate a lot of stuff like tracheostomy, a lot of suffering, and
well, I'm very sensitive to the demands on your time, and the family's been kept waiting quite a bit. I'll just ask some very brief questions, and we'll get them in here. Would that be okay?
Sure.
Do you know if she has any advanced directives in her chart or somewhere else?
I don't think so.
Okay. I didn't think so either, but
I think she has expressed something, but I think there's nothing like written or something more legal.
And my understanding is that her son and daughter are the surrogates, decision makers right now, is that correct?
Yes.
Is there anybody else we should consult as a decision maker or surrogate?
No. I think that they're both are the POAs.
Okay. All right. What's it been like to treat Miss Henderson? And has it been hard treating her, or what's your reaction to you and your team treating her?
No, this is understandable. I will say there's no standard case, but this is a ischemic stroke, and it's not the first case that I see. I've seen similar stroke cases before, where we get to this point that we have to decide what to do. So it's, the challenging part of this case is not the medical treatment, it's the decision of what to do next.
Okay. My reading of this, talking to people, is that the ethics consult was called because families divided on what they do, which kind of puts you in the middle. And I wondered how uncomfortable that was for you. It sounds like you're kind of used to being in the middle.
Yeah, I'm not well, as I said, I don't want to give up. I mean, at the beginning, I'm very kind of defensive to withdraw care that fast. And it seems that's what they want to do. So, yeah, I'm in the middle because I would like to give the patient a chance to see if nothing happens, and I'll take the decision with the family, or I'll be part of it.
So would it be fair to say that your hope for her is that you'll be able to assess her and she'll have some chance of recovering quality of life, to what you fear is withdrawal is just premature right now? Is that?
It is premature.
Okay, that kind of capture it in a nutshell.
I will say it